Welcome back, everybody, from that quick break, and we do apologize for that slight delay. But welcome back for our next session with Dr. Stuart Peacock, focused on life beyond cancer, thriving in survivorship. Thriving in survivorship. Dr. Stuart Peacock is a professor and Leslie Diamond Chair in Cancer Survivorship in the Faculty of Health Sciences at Simon Fraser University. He's a co-director of the Canadian Centre for Applied Research in Cancer Control, a distinguished scientist at BC Cancer, and a fellow of the Canadian Academy of Health Sciences. Stuart has 30 years of experience in health economics, quality of life research, public engagement, and priority setting in health policy. His interests include developing more effective cancer services, making health system funding decisions fairer and more transparent, and improving the quality of life of cancer patients and survivors. It is an honor to be here with you today, Dr. Peacock, and an immense honor to pass you the virtual floor.
Now, I'm hoping everyone can see my slides correctly now, because I'm on presentation mode, but welcome everyone. Apologies, we're running a few minutes late, a few technical difficulties as they usually are. Thank you for the very kind introduction. I'm going to talk a little bit about some of the survivorship research and some of the issues we're seeing in survivorship during this session. I'm going to give you a bit of a whistle-stop tour of some of the research that I'm involved in and our team's involved in, but there's lots of good stuff going on across Canada at the moment.
Dr. Peacock, just to be transparent, I don't believe we can see your slides currently.
Let me do that again then. That was what I couldn't tell from here whether you can see them or not.
Down at the bottom, you will find that share button.
You can't see it at the moment. There it is. All right, there we go. Can you see it now okay? Yeah.
Right now is in presentation mode.
Right, so this is the mode that it's going to stay in. I've had this problem before. I've realized what the issue is there. So what I'm going to do is I'm going to make this as large as possible, and I hope you can see that okay.
Okay, thank you. Yeah, we can see it.
Yeah, right.
Thank you, Dr. Peacock.
Sorry about that. That's another thing to do with Zoom again. I want to first off acknowledge that I live and work both in Burnaby and Vancouver, as we know the names now, but these are the unceded traditional coastal Salish lands, including the Tsleil-Waututh, Coquitlam, Squamish, and Musqueam nations. SFU and BC Cancer and the government is committed to moving forward in a meaningful way, reconciliation endeavours. So if we go to the declaration side of things, I'm going to talk a little bit about this later. I'm not generally involved in anything to do with proprietary medicine or private sector stuff. I am the vice chair of the board of directors for Inspire Health, which is a non-profit supportive cancer care provider in BC. And I'm going to talk a little bit about them later on as well. They're doing some great work in the community and with cancer survivors, supporting them throughout the rest of their lives. So here are some of the data. You may well have had this type of slide presented already at the conference earlier on in the week. This is from a couple of years ago. The CCS, Canadian Cancer Society, puts out these data in conjunction with the government each year. Cancer, unfortunately, is the leading cause of death in cancer in Canada. But that actually is because we've got much better at treating heart disease and things like that. Our population is aging. And cancer tends to be more prevalent in older people. So we see more cancer emerging in the community. But the reasons are good reasons. We're living longer and we're not dying from infectious diseases or cardiovascular disease in the way we used to. About 2 in 5 Canadians will develop cancer in their lifetime. That's now closer to probably 1 in 2. All of us will have been touched by cancer one way or another during our lifetimes and multiple times. The 5-year survival rate is getting around 64–65% for adults. For children, it's much better. It's around 80%. These are massive shifts in the last 30 to 50 years in terms of survival. And as Philomena mentioned during the break, we're busy transitioning this disease away from being a highly fatal disease in, all or most cases, to something that we can manage more as a chronic condition later on, whether you've gone into full remission or whether you're actually living with metastatic disease and we're using new therapies to try and manage and control that. from a kind of a chronic condition type of perspective. So let's talk a little bit about survivorship. It's a very broad definition. It can be a little bit challenging at times. This was first kind of worked out in the mid-90s in the US at the National Institutes of Health. Cancer survivorship is a state of being, including the perspectives, needs, health, and the physical, psychological, social, and economic challenges experienced by people and caregivers after a cancer diagnosis. So it is a very broad definition. It includes the individual who's experiencing cancer, their family members, nearest, dearest, and loved ones as well, because they are touched by this disease, but also become very important in the care process. And it includes the wide range of the impacts of cancer on the person or the individual. And in the way I think about things, cancer survivorship is about the person. The treatment of the original cancer quite often is a biomedical type of approach, in the sense that we need to treat this disease, otherwise it may develop into something much worse for the individual. But later on, we spend more time with the individual working out what the quality of life impacts are of a cancer diagnosis and how we might best help people as they try and find a way through these things. I personally try not to use the term journey, because I've met enough patients who said, this is not a journey I chose to go on. So when I'm talking about these things, I'm talking about the trajectory after a cancer diagnosis. One of the critical things, though, for survivorship now is we consider that someone is a survivor from the time of diagnosis throughout the remainder of their life. So that means we don't have this artificial kind of, you're not a survivor unless you're 5 years out from your diagnosis or not. That was a type of thinking that we used in the past, but now we use a broader approach. Key components, and some of this is actually relatively new still in the cancer space. Comprehensive care starting at diagnosis, we've been doing for a long time. Assessment and mitigation of treatment impacts, we've been doing for a long time. But this focus on the psychological and social well-being that's come through the survivorship work is fairly new still. And it's not something that the mainstream part of cancer services has been thinking about up until about 20 or 30 years ago. And you can see here, this is a slide we use in BC, the cancer agency here, the trajectory of a patient or patients going through the cancer system, and the range of different places they can end up throughout that process. And you've got here some notion of getting better at the top there with survivorship, or living with the illness, which is kind of recovery survivorship. This bit here with primary care is the big unsolvable problem in Canada, and I don't think we're going to find a solution in the current approaches. There is an important interface for survivors between the primary care sector, supportive care services, and the cancer agencies or the cancer hospitals. And at the moment, one of the things in Canada that we don't do very well is that interface with primary care. And part of that reason is that the primary care sector is particularly stretched here at the moment. So there are some challenges for an individual going through cancer, because our health system has various gaps and things that need attention. That's not unusual, but it's a particularly Canadian problem at this moment in time. And these are the types of things, and I'm going to come back to this later on, that we think about as cancer survivorship care at the moment. Monitoring for recurrence of new cancers. You've heard a bit about that already with the conference. Promoting healthy behaviors. You will hear on the prevention side of things, between 50 and 60% of cancers are actually preventable, and a lot of them are to do with diet and exercise and all the good public health things we talk about. Coordinating care is tremendously important. It's not something we do that well at times. Managing comorbidities that may come from late effects. And then you've got discussing goals of cares, supportive services. We are moving into a world where we will assess genetic risk for all cancer patients and do genome sequencing for all patients, because this will help us manage their disease later on, or help them manage their disease. And then there's a whole load of social and financial impacts that come from cancer. And I find these ones interesting because that's the type of world I've come from in the past. I like to put some faces to names here. I put up members of our research group. You'll see there are about 10 or 20 of us at different times and a whole bunch of students. This is a very active area now, cancer survivorship. There are a lot of research teams looking at this. There are 6 or 7 I can think of in Canada at the moment that have similar teams doing different types of work for survivorship. One of the things I want to mention, though, specifically for BC and what we're doing, and I like to raise it to an audience like this as well, because we are trying to get survivors involved in research more, and patients as well, depending on how you define everything. And this has been a big push in medical research of the last 15 years. What we're trying to do, we do a lot of work with younger individuals experiencing cancer, is we have tried to get people who are students at universities to become involved in research projects, and we work with them and mentor them in research projects that tackle the disease that has usually touched them very directly. So we have a student here, Janine Ho, who comes from Vietnam, who was the primary caregiver for a mother who passed from cervical cancer. She's working on how do we reduce barriers to care for recent migrants into the community. Mary De Vera, who may be very well known to some of you, is a professor at UBC who experienced colorectal cancer at a young age, and she has done an awful lot of work with her research team in trying to tackle early onset colorectal cancer. So the types of research that I'm going to flip through very quickly to give you this overview, I do something called health services research. That means I look at how we provide healthcare services to different individuals, different populations, different time points, and how do we do that so that we can provide the best quality care for individuals. This uses all kinds of different kind of mixed methods, which is qualitative and quantitative methods for research. So this is what we define the cancer survivorship research kind of circle to look like. We have a whole bunch of different issues that might be impactful on individuals and their families as they go through cancer. And this lines up, if you like, a little bit with the cancer care slide that I showed previously. So what I'm going to do now is just talk about the types of things that we do. The first one in BC that I like to highlight is our Childhood, Adolescent and Young Adult Cancer Survivors Program. So these are 0 to 39-year-old individuals. We think of adolescents and young adults as ranging from 15 to 39 now. This is particularly important with this type of conference because it's through these data that we are picking up things around changes in incidence and prevalence of colorectal cancer in particular. It's through these types of data sets that we notice that the incidence has changed over time for younger people. So we are using data there that follows every person who got cancer in British Columbia who were aged 0 to 39 years. We've got all patients from 1970 to 2020, 50 years. So I don't believe anyone else in the world has a data set quite like this at the moment, where we can look at all the young people who got cancer in the province over 50 years, and we can start to study incidence and prevalence and reasons why we think things might be changing. So we're quite proud of this, I think, in BC. The original program was looking at just the younger people under 25 years. Recently, we've expanded and enhanced the data sets that we've been using. And I showed this slide because it helps to understand that when we're talking about survivorship, we're talking about something much more holistic than just treating a tumor. The data sets that we look at include all the data sets from the health system that you might expect. Data on drugs, data on inpatient admissions, data on going to the emergency rooms. But we also collect data and link it to all of these patients on education and childcare outcomes. So for the very young patients, we're linking that to understand what happens to their schooling and their education if they are diagnosed with cancer and have that massive interruption in their developmental phases. We have income data, which I'm going to show in a second, to see what the impact of cancer is on household and personal income over time. And we have data, and we haven't looked at this yet, but we have data from WorkSafe BC from their injuries and claims. And I'm going to talk a little bit about the importance of things like WorkSafe BC data in a second as well. Lots and lots of data in this data set. Don't need to go through all the details here, but we have approximately 50,000 young cancer patients in this data set. And this is the good news story. This is for children aged between 0 to 14, and this is the age standardized mortality ratio. So this is the death rate per million for all types of cancers by biological sex, boys and girls. And you can see the blue line shows you that the mortality rates from cancer for children are falling very significantly over time. And the rate of fall was quicker for boys than for girls. So the improvements were quicker for boys than girls. And we do tend to see a little bit more cancer in girls than boys at this stage of their life. But this is the good news story, and the advances with the genomics and the precision medicines in the last few years has made a big difference in terms of driving down the death rate. And like I said, I think about transitioning cancer from being an acute disease that's highly fatal to a chronic disease that we manage over time for individuals. So we saw in this population here that we've got higher incidence of cancers for our AYAs. These are the adolescents and young adults. So females have higher cancer incidence. Sorry, more boys with childhood cancers. We have seen, and the two big ones that you are now seeing in the news talked about as well, is thyroid has gone up a lot, and gastrointestinal cancers have gone up. The thyroid we think has gone up because we've reclassified thyroid cancers in many respects. So we're measuring them differently. But the GI cancers, the colorectal cancers, are the ones we are concerned about. And as you are likely very well aware, there are lots of research teams working very hard to figure out why the incidence is rising in the younger people. And as yet, we don't have a fully satisfactory answer about why that's happening. So I wanted to show some data. This is a big study that we've done nationally looking at cancer survivors to see what happens to their income over time. I'm going to show you the raw data to start with. And at the top here, so on the vertical axis, on the left-hand side, you can see it says mean individual after-tax income. Along the bottom, years since diagnosis. And we have some survivors here, and the survivors who are male are the blue, and the survivors who are the female are the red. And then we have a control that we compare these two, people who don't have cancer, to see what we find is the difference between those who experience cancer and those who don't. So the first thing you notice whenever you get a graph like this is the women's, the female income is much lower than the male income. And we know this in lots of societies. It's partly due to inappropriate disparities in wage rates, but it's also partly to do with full-time and part-time working patterns. But what you see here with this graph is years since diagnosis, there is a drop in income for both males and females. And looking at the raw data, it looks like women experience a bigger drop in income after cancer than men do. But they rebound after a few years. These are working age individuals. And we think that what's happening here is there's a compensatory effect where people are trying to work harder, having had a diagnosis, lost their income, and then trying to catch up later on. And when you do the kind of statistical analysis, this graph shows you the same pattern. The female is this light purple triangle. The male is the blue rectangle square. The dip in income after a diagnosis of cancer is more pronounced for a female than it is for a male. And the compensatory effect that we've noticed here of women working harder later on in life, that is borne out by the data here as well. I should add with that, because this is not something that we've seen very often in Canada before, that looking at the international studies on this, the Americans have the same pattern in their data as well, that women tend to be hit harder on terms of income and then tend to, if you like, try and compensate more over time after their cancer diagnosis. The type of cancer you have also does make a difference. Pancreas, this is the amount of percentage change in income after 1 year after a diagnosis. And you can see that people with pancreatic cancer have had a 17% reduction in their income in the year directly after diagnosis. And part of that will have to do with the fact that pancreas is often diagnosed very late and is very aggressive and highly fatal. If you look at colorectal, it comes out in the middle of the pack there, about an 8% drop in income the year after a diagnosis. So this is when lots of people are trying to juggle all kinds of life commitments while being treated. The policy implications, the first one I would say, or the most important one, and the EU has recognized this, for breast cancer patients, many women experience breast cancer do so at a fairly young age while they're still working. And that the breast cancer population is very large and is an important part of the economy. So in the EU, there are actually now targeted programs trying to get women who have experienced breast cancer back into the workforce. And when I say back into the workforce, that doesn't just mean showing up to work, because lots of cancer patients experience fatigue, anxiety, all kinds of other things. So it means not only getting people back to work, but supporting them and helping them work in the right environments on the right jobs or the right tasks. So there's a very important piece here, because we're going to have a large number of people experiencing cancer who are working age, and this is going to be very important both for them, but also for the wider economy. We're looking at children as well at the moment and adolescents. How do we get them back into the classroom having experienced a cancer diagnosis? And there are all kinds of nuances, as you can imagine. We do very little in most provinces. Ontario has a good program, but elsewhere, not so much, of how do you reintegrate younger people back into their education after they've had a diagnosis of cancer. And obviously with the children, that includes also how do you work with the peers in the classroom so that they can understand and accept the things that are going on around them when one of their classmates goes through cancer as well. The income data has shown us that if you get an interruption to your education, it's quite likely your income is going to drop later on in life. And these are important developmental stages for individuals. People are working out who they are, where they come from, who their friends are. If it's an older person in their 20s, they might be thinking about whether they're going to start a family at some point, and then you get a cancer diagnosis, which puts a spanner in the works for all of that. And I wanted to point out as well that we are looking more and more now at the mental health needs and outcomes of survivors. Approximately 75% of people who experience cancer will have fear of recurrence. That's probably the most common late effect that we see for most people. But there are a range of mental health needs that I don't think we yet have much of an understanding of, that I believe we should be helping people with through the survivorship phase of their lifetime. I'm not going to talk about these slides here, but one of the other things we do is we look at real world data when drugs get introduced into our cancer systems. So we're involved in doing parts of that. But I do want to talk about this next part a little bit more in depth, because this is where we're going, I think, anyway. This will be my 2 cents worth. We talk about people employed in the health sector as health human resources some of the time. We have a health human resources problem in Canada, but most countries have a problem at the moment that we simply don't have enough trained medical practitioners, health practitioners. And we are essentially competing with other jurisdictions and other countries for the same pool of trained individuals or individuals who are going through training. So in British Columbia, we felt this very acutely when we ran out of radiation technologists at one point. It's not always that. Like I said, primary care, we've had some problems there. So the biggest priority amongst the cancer agencies at this moment in time is how do we strengthen the healthcare workforce? Because we know since COVID that we've lost quite a few people, and we now have quite some fairly acute shortages. But we are going to have to be quite innovative in how we deal with this health human resources problem, because we are competing with all these other countries as well. And we are simply not going to be able to recruit enough people into the health system to staff it in the way we would want. So we are working with the CEOs of the cancer agencies at the moment, looking at virtual care, how we can use that responsibly. We know from COVID that your first couple of appointments with an oncologist should be in person, whatever. But virtual care is acceptable and preferable for some people later on in the care process once they've established relationships with their care team. We have to look at artificial intelligence. That's going to be a useful tool. It's not going to replace a lot of things, at least not anytime soon, but it's going to be a very useful tool. But I do want to dwell a little bit on moving care into the community more, because I hear this regularly from patients that if we could provide care closer to their home, this would be highly desirable. And obviously, we have a lot of problems in Canada with our geography, and that this might, providing more care in the community, might help address some of the disparities we see based on the difficult geography we have in lots of parts of Canada. So we are working on that at the moment, and working with a team in Denmark who have implemented home-based chemotherapy. And I think this is a really positive move. And we can't do all types of chemotherapy in the home, but there are some that we can do in the home. And generally, I find that people would rather stay in their home to get care for a difficult condition than go into a hospital setting. I think there's lots of good reasons for that. So this is taking up a lot of our time at the moment, trying to work out appropriate models of care. And in the context of survivorship, this means having an appropriate way to deal with your primary care physician, if you have one, your oncology team, any community-based programming that you're receiving and the like. So there's some complexity to all of this, but I think we're moving hopefully in the right direction. And I'm going to show you two things we've done. We've just completed. The first one was COVID. And we worked with 43 other countries. It was quite remarkable how quickly things came together to look at what happens with COVID and cancer. And does it impact your cancer risk, or does your cancer impact your risk of death from COVID and the like? So we spent several years working on what happened during COVID and how did that affect cancer patients. And it did have a big impact, particularly in that kind of first 18 months when there was no vaccine, or we weren't close to the vaccine. The big thing some of you may have experienced was we closed down in lots of jurisdictions in Canada. We closed down our screening programs during the initial phase of COVID, when we essentially didn't know much about what we were up against. So these graphs just show, in these cases, they're both mammography, and it shows the dip, the big dip down there, where we shut down the screening programs and then reopen them later. This was highly concerning at the time. We were extremely worried that by doing this, what we were doing was storing up a whole load of extra cancer cases for later that we were going to miss by not having the screening programs running. Some of the decision makers I've worked with have said, in the future, we should not do that. If this type of event happens again, we should keep going. And the other thing I'm glad to say is we work very hard with these countries around the world to come up with strategies to address the people who didn't get screened during those 3 to 6 months' time. Essentially trying to find high-risk people and screening them first, so that we can build up the program again. So the impact of COVID wasn't nearly as bad as we thought it might be on stalling all this disease, because people didn't want to come in for screening. That was through a lot of hard work from finding high-risk individuals after the initial phase of COVID was over and screening them then. I've already mentioned with the virtual health could be a very, very powerful tool, particularly for equity, particularly for our people who live in remote places or places that are difficult to access. We've got some good data that shows lots of people are quite comfortable using virtual health later on in their care process when they've established these relationships. But if you get it wrong to start with, people really struggle with the virtual health approach. So we have to be very mindful about how we deliver it like that. And I just wanted to highlight a couple of other things that are going on there. We have a lot of diversity in the world. If your sexual identity is gay, quite often, if you're a prostate cancer or a breast cancer patient, you will have different issues on your mind than you may be if you were heterosexual. We know that health outcomes for gay people tends to be poorer for prostate cancer and breast cancer. So I have a student working on what are the issues here for that particular group of individuals about why their outcomes are poorer and what we can do to improve them as well. Mary is very relevant, and I know she's involved with CCRAN. Mary got colorectal cancer in her 30s and has been researching her own disease for some time now. She also had a very, very good PhD student who's been looking at sexual healthcare and outcomes from younger patients. So this goes back to the remarks I made earlier. For our younger patients experiencing cancer, there are some very tough decisions and conversations around preserving embryos and things like that, because you're getting some very toxic treatment for your cancer at a time when you might be thinking about starting a family. And this is very challenging. So we have some good work. We've got quite a lot of work going on reproductive health and sexual health at the moment. If you are living in 2 or 3 places in Canada and you're a younger person, they have dedicated programs, cancer programs. We don't have one in BC at the moment, but my colleagues are working to address that. So I'm going to wrap this up by a couple of final slides. I wanted to come back to Inspire Health in BC. This is a non-profit supportive cancer care program. I'm highlighting this because I'm familiar with them and I like the work that they're doing, obviously, and I'm invested. There are other organizations that look a bit like this in Canada. They're a bit disparate at the moment. But these are an organization that provides things like exercise and movement classes, nutrition and cooking, stress reduction and counseling, education, supportive cancer care physicians, and programs for support people as well, a lot of peer support. Now, I want to be a bit controversial here, but because I've been thinking a lot about this lately, and in a lot of health systems, you see different ways of organizing things to get things done. And I am genuinely concerned that we've lost track of the human being, the person in our cancer care at times. And that's not a criticism of the cancer system. It's because things are pressurized and even much more pressurized now than they even were 10 years ago. So if you going through appointments, quite often it's very much a conveyor belt. It's not dehumanizing, but it's also there isn't the time to have that human aspect in the care process always. These types of organizations like Inspire Health are an innovative solution to a problem that I think a lot of people can see is how do we take care of the survivor themselves? And I do think that this type of approach where you have community-based organizations and some kind of relationship between a non-profit, profit and the health sector, some kind of partnerships are going to be necessary to provide the right supportive cancer care. I just don't see the health system being able to take this on with all the other things that it's doing. And given the state of our primary care in Canada, I'm actually very optimistic that this community-based approach is a good way forward. I just think we need to think very carefully about what the government-funded health system can and cannot provide during difficult times. So come back to the last slide here. I'm returning to the cancer survivorship care. So here are all the good things that we should be doing for our cancer patients going forward. This is my kind of ideal world that we would be looking at all of these types of things. And I know you have a session coming up on exercise, which is great. That's one of the biggest areas of research in recent years. And it turns out that exercise both before, during, and after cancer is a good thing, and it improves your outcomes. It's going to be a challenging area. I mean, not many people feel like doing exercise while they're going through treatment, but it's an interesting area for sure. So I'm going to leave it there. If you have any questions or would like to reach out, I have 2 email addresses. You can use either of those, and you have some websites there. And like I said earlier on as well, we're really keen on the research participation. So if you have questions you'd like some answers to, great. If you would like to find out more or become involved more, that would be wonderful too. Please reach out.
Thank you very much, Dr. Peacock, for your presentation, and of course for being here to help inform our coaches and viewers today. We fully agree having more patient engagement would be incredibly helpful in so many ways, and we're definitely here to try to grow that awareness, to improve participation in an effort ultimately to try to support healthcare equity across the country. So thank you very much for that empathetic lens. And to anybody watching, please do reach out if you're interested in getting involved. We're here, and we will certainly be there to support putting you into the position where you can volunteer if that's what you're looking to do, or provide your very valuable patient or caregiver feedback. Okay, so for now, our silent viewers can now head back to the lobby to join the next session, which will take place at 1 p.m. with Dr. Adams, and our coaches will now head backstage for their question period with Dr. Peacock. We will see everybody at 1 p.m.